Great. Well, thank you. Thank you all for making it out here. Since George isn't here, I figured I would welcome you to the Twin Cities, where winter lasts a lot longer than in other places. But I wanted to just do a few things, and I probably won't even use the full 20 minutes. I'm going to set some context and talk a little bit about how I think about health literacy. I'm going to briefly discuss the existing policy levers. And in that context, I will actually mostly just give some examples of some of the challenges that we faced at ONC, the Office of the National Coordinator for Health IT in the Department of Health and Human Services, when we were developing the meaningful use regulations and thinking about how to evolve that program. And then really, what I really want to tee up and looking forward to the discussion is really sort of the policy challenges and the balancing act of policy and the implications of certain decisions in the policymaking process and how hard it is to get things right in terms of health literacy. So I think it's always important to think about health literacy in the context of understanding what people say and what people hear, let alone what they remember. A great Far Side cartoon is, the owner telling the dog, okay, George, I've had it. You stay out of the garbage. Not George, Ginger. Ginger, understand, Ginger. What I say out of, when I say get out of the garbage, stay out of the garbage, or else. And of course, the dog just hears blah, 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 Ginger, blah, 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 Ginger. I've heard this from many patients that I've talked to in the context of a serious diagnosis, particularly something like cancer or other life-threatening illness. Once that word cancer hits them, everything else is kind of a blah, blah, blah. And so it's not just a lot of it is the context of what people, where they are when they're hearing something and trying to make sense of that. There is a lot of research that suggests that 40 to 80% of everything that is communicated by a clinician in the doctor's office is completely forgotten by the time he or she gets home. And I think we need to think about what that means. I also want to put it in context of kind of thinking about taking yourself out of your healthcare environment and putting yourself into someplace else. And I'm going to use two examples. So the first is one I heard maybe 10 years ago. There was somebody who was on the board of, kind of a patient representative on the board of the National Patient Safety Foundation. And there was this long discussion about health literacy. And she felt that it was really patronizing. And at a certain point, this is a woman whose day job was working in the post office. And there's a group of, probably not too dissimilar from the group here. And she said, okay, how many of you know the difference between certified mail and registered mail? And not a single hand went up. And she said, it's not that you're all illiterate. It's not that you don't understand things. It's not that you're not smart. It's that there's this specific knowledge related to something very specific, and you don't understand in that context. And the second example is something that I get a lot every day. We talk about health literacy at 4th grade levels, at 6th grade levels. Well, I actually have 2 6th graders and a 4th grader. And much of their typical dinner conversation includes something called Minecraft. Now, for those of you who don't have 4th or 6th graders, you will not understand this, but trust me, neither do I. But this can consume many, many hours if left unattended. I literally will be sitting at the dinner table, there will be these conversations going on, and I really don't understand it. So I actually, last night I asked one of my 6th graders to give me some instructions. I said, pretending I'm moving on from one place in Minecraft to another, right? Like a transition of care. And I said, okay, if I'm going from one place to another, can you give me some pointers? And so this is what he said, basically verbatim. When you go into a server that requires getting more materials, first get wood to make a basic pickaxe, then get stone for an upgraded pickaxe, and then use the stone to upgrade to iron and gold. Because iron and gold, because iron ones can get you diamonds, which are the best. Once you get the diamonds, you can use them to craft into armor tools and weapons. Once you have those essential tools, then you can use them to buy other things and possibly create a faction. Once you build a faction, you can build an alliance with your friends as well as alliances with other factions, and together you can raid bases with them. So that is his instructions to me about what to do, and by virtue of that, now I should be ready to just go out and build a faction or an alliance or something like that, and with all that, I'll be in good shape. So I think it's just important to really understand that that information that's being imparted is very much related to someone's background, someone's context, and to understand that. So I'm going to run through first just a little bit about CMS and then spend most of the time on ONC, just because I think that's where I can give you some examples of some of the challenges and how they played out. So there are requirements, and this is also similar to what the Joint Commission has, that there are discharge requirements that require educating patients and caregivers about their post-acute care facility plans. This is when they are being discharged from acute long-term care or rehab hospitals. They need to be given written and verbal instructions on their post-discharge options, on what to expect after discharge, and what to do if issues arise. And they need to be provided, there needs to be after that, after a period of time, an evaluation of the patient and caregiver's understanding of needs. What of course that leaves the question as to how are they going to evaluate that understanding, and how are they going to ensure that that really is meaningful, and that they can really that there is a deep understanding. And I think that there is a lot of challenge in figuring out how to put that into the CMS expectations. So, for those of you unfamiliar, the meaningful use of electronic health records was basically an incentive program started 5 years ago as part of the American Recovery and Reinvestment Act to ensure that incentives were not just for adoption of electronic records, but for actual meaningful use of those EHRs. And what came out of that was a whole domain around patient and family engagement. And it included, 4 things that are very relevant to the discussion today. One is that if patients wanted them, that they were entitled to electronic discharge instructions. That every visit needed to be, that at the end of every visit, there needed to be an after-visit summary on the outpatient side, so that as I said before, 40 to 80% of everything heard in the doctor's office is completely forgotten by the time that person gets home. So having an after-visit summary can help. Patient reminders, and actually it's not just for preventive care. A lot of people think those are reminders for, cancer screenings and immunizations and things like that, which they can be, but they can also be for follow-up care. That's also very relevant to the discussion today. And then, importantly, patient-specific education resources. And this really was the idea that information should be prescribed after visits or after inpatient stays to patients and their families to ensure that any other information was put into some context, was provided alongside some education, and that education could be understood. Now, in the ideal world, prescribed information is patient-specific by being targeted to the moment in care. That is, it is a new diagnosis of diabetes would trigger information that is specific to what diabetes is about and what you need to know about it. And tailored to the individual's own circumstances, needs, and expectations. And that latter part is really hard to put into regulation. And so, in an ideal world, we would know if, what is the the literacy level, the health literacy level. There are, and as I talk more, we'll talk about some of the evolution of this, but what languages people speak, trying to understand what kind of information they best consume, right? Some people would prefer to get written information, some people would prefer to get graphical information, some people would like audio, some video, and we can do all of that now. And it's also how that information is communicated. Should that information be communicated on a piece of paper? Should it be communicated via one of these devices? Some mobile device? Should it be communicated through some other mechanism? And so all of those things affect the specificity in the patient-specific education resources. And certainly in stage 1 meaningful use, there was not a lot of detail as to what that is, except that you had to use data from the EHR to identify those resources. In stage 2, there are stage 1 went into effect in 2011. Stage 2 begins this year, and there are some new objectives that are very relevant to this discussion. One is that patients have the opportunity to view, download, and transmit information, which is to say that they can, in a sense, export whatever information is collected in an EHR into their, into a way that they can use it. Now, again, that doesn't necessarily mean that they're going to be able to understand it, and so there is now a lot of work being done to figure out how to make that more possible. What I will say is that, and I probably should have said this at the beginning of this discussion, organizations that develop products that are electronic health records or components of electronic health records, they need to get certified in order for those to count for the incentives. And the certification can be for a complete EHR, or it can be for EHR modules. So there are several organizations and companies now that have gotten their sort of patient-specific education resources certified just for that meaningful use objective. So organizations that you've probably heard of, like HealthWise and Crames and so forth, have gotten certified just for those modules, and those organizations have spent a lot of time thinking about how to make information understandable to consumers, patients, caregivers, et cetera. Secure messaging, so that clinicians are accessible via secure email. What is important about those two objectives, if you download, well, one of the things important about those two objectives, the VDT and the secure messaging, is that for the first time, providers actually have a responsibility to communicate for their patients to use these things. That is, there need to be a certain percentage of patients that actually send them a message. There need to be a certain percentage of their patients that actually go online and view, download, or transmit their information. And the reason is because just making it available, we found out from stage 1, doesn't mean that it's actually used. And it may even be almost a big secret that this information is available, or that you can get your discharge instructions electronically, or any of those things. And so it was felt that it was really important that there be an expectation that providers would actually meet a certain threshold. And it's a pretty low threshold, recognizing that there's a lot of variation in populations, but that they would need to meet a low threshold in order to ensure that there is an incentive for them to encourage usage among their patients and caregivers. And then the last one is really important for this discussion. It's around the transitions of care summary exchange. Now, this is primarily around ensuring that transitions of care summaries are shared among different providers. So when someone leaves an acute care setting and goes to a rehab setting or long-term care setting, that there is an opportunity for that information to be available at the new site of care. But there are also some important things included in that, those expectations around what should be included, and it lays the groundwork for further expectations in the future around what shared care plans should be, what the expectations around that are. The other thing about in stage 2 is that there was more of an effort made to at least identify what patients' preferred languages are, so that they can, that's obviously the first step, that the EHRs are actually able to record that, so that we can tell if people are meeting that. Now, in the proposals for stage 3, which are just recommendations now from the policy committee to HHS, that those recommendations from the policy committee are suggesting that there be certain requirements around additional languages besides just English, and so that's obviously an important piece of that as well. So really what I'd like to do now is just tee up for discussion some questions that really reflect some of the things that we faced and really struggled with. I think that there are obviously CMS has a variety of levers. There obviously are also many levers in the private sector through standards organizations like the Joint Commission, NCQA, and others. I think there's a lot of question about how much should come from the federal government versus the private sector, and if left up, and if it should be public policy driving it, to what degree should there be federal versus state expectations around that? I think the biggest question is the one at the bottom, and this is the one that really just continues to confound policymakers and many others, is really this balancing act between ensuring that all the things that we really want are included in the expectations, right? So there are a lot of things that I'm sure, and I've been present at a couple of these other at these meetings over the years, so I know the really insightful comments that come out of this group around what should be expectations around health literacy. But when you codify that in a regulation, you suddenly create a series of in some cases, this becomes a little bit of a game, and providers sometimes will try to figure out, how do we figure out how to meet this objective? How do we make sure to check that box? And that can be a challenge. And of course, the biggest concern is that it could be potentially overly prescriptive, that you could ultimately do something that would really stifle innovation. And that would really be the biggest concern around what the drawbacks are to really specific regulations. So these are the questions I would like to discuss, and I hope that you have others. So I look forward to that discussion. Thank you.